Welcome. Today we're doing a targeted review of craniofacial clefts. This is obviously a really crucial area for surgical trainees heading into board exams.
Absolutely. The aim here is a concise but still comprehensive look at the embryology, the pathogenesis, classification, and, the key features you need to know.
Right, because that deep understanding of the anatomy and development, it's just vital for planning surgery and getting good outcome.
Exactly. You really can't overstate its importance.
Okay, so let's kick off with the embryology. We're talking weeks 3 through 8, primarily.
That's the critical window. So weeks 3 to 4, you get the front nasal prominence starting things off, developing the nasal and olfactory placodes.
Right, from the forebrain.
Correct. And these invaginate, forming the medial and lateral nasal processes. Now, the medial one, that's key for the nasal tip, columella, philtrum, and the premaxilla.
Got it, and the lateral.
The lateral nasal process forms the nasal ala. At the same time, you've got the mandibular arch splitting into the mandibular and maxillary processes.
And they migrate medially.
Yes, they move inwards to form the lower and upper mouth, respectively.
So the mid-face formation then follows in the next couple of weeks.
Exactly. Weeks 5 and 6, the nasal processes, they enlarge, migrate, fuse in the midline, and also fuse with the maxillary process.
And that completes the upper lip.
That coalescence completes the upper lip and really sets up the whole mid-face structure.
Okay, clear. Let's shift to pathogenesis. How do these clefts actually form? What are the main ideas?
Well, there are two main theories we talk about. The classic one describes a failure of fusion between those facial processes we just mentioned.
So things just don't join up properly.
Essentially, yes. Specifically, the maxillary processes are thought to fuse with paired globular processes, which are under the nasal pits. Normally, you get epithelial contact first. Then mesodermal penetration sort of zips it up, completing the fusion for the lip and primary palate. If that sequence gets disrupted at either stage,
You get a cleft.
you get a cleft. Exactly.
And the other theory, the mesodermal penetration one.
Right. That one views the developing face a bit differently, like a bilaminar ectodermal membrane with epithelial seams marking where the processes meet.
Okay.
The key here is the migration of mesenchyme. It needs to penetrate and smooth out these seams. If that penetration fails or is insufficient,
The scene stays weak.
precisely, the epithelial walls lack support. They can break down dehiscence, and that forms the cleft.
Interesting. Two different ways to think about the same underlying problem. Now, classification is obviously key for discussing these. How do we categorize them?
The main system, the one you really need to know, is the anatomic classification from Tessier. It straightforward assigns a number based on the cleft's position relative to the midline.
And the Tessier diagram is the go-to visual for that.
Absolutely essential. You need that diagram in your head. There's an embryologic classification too, based on an S-shaped developmental path, but honestly, it's not really used much clinically.
So we'll focus on Tessier. Let's start with the oral nasal group, numbers 0 through 3, affecting the lip and nose between midline and Cupid's bow.
Right. Tessier 0 involves midline structures. It can present as either deficiency or excess. Deficiency means maybe absent soft tissue in the upper lip or nose, sometimes hypotelorism, even holoprosencephaly.
And skeletal.
Skeletally, you might see an absent premaxilla, a secondary palate cleft, or missing nasal bones. On the flip side, excess tissue could mean a duplicated frenulum, a bifid nose, hypertelorism.
Okay.
Skeletally, maybe a diastema, a keel-shaped alveolus, broad and nasal structures. And importantly, this can continue upwards as a Tessier 14.
Got it. And Tessier number 1.
Tessier 1. Soft tissue-wise, it looks a bit like a standard cleft lip and palate. It runs through the lateral Cupid's bow into the nose. You might get notching of the dome or soft triangle, and it can extend up towards a misplaced medial canthus.
And the bone.
Skeletally, the cleft separates the nasal floor from the piriform aperture, the nasal bone from the maxilla's frontal process, and it sits between the central and lateral incisor. It's also called nasoschisis, can extend up as a Tessier 13.
Okay, what about Tessier number 2?
Tessier 2 starts similarly, lateral Cupid's bow, but extends into the alar rim lateral to the dome. The ala itself is often hypoplastic, nasal tissues flattened, medial canthus is displaced, but crucially, the lacrimal duct is usually spared.
Skeletal features.
Skeletally, it cuts through the lateral incisor into the piriform aperture. Again, hypoplastic ala, this one's pretty rare actually, can extend as a Tessier 12.
Right. And rounding out this group, Tessier number 3.
Tessier 3 is more common, can be unilateral or bilateral. Soft tissue. Starts lateral Cupid's bow, cuts across the ala, through the frontal process of the maxilla, right through the nasolacrimal duct into the lacrimal groove.
So lacrimal system involvement is key here.
Definitely. Often blocked anomalous drainage.
Mhm.
You see a superiorly displaced alar base, a foreshortened nose.
Hmm.
Lower eyelid colobomas are possible, and the globe can be malpositioned inferiorly and laterally, risk of corneal exposure there.
And skeletally.
Direct communication. Oral, nasal, orbital cavities can all connect. The cleft lies between the lateral incisor and the canine, and this one can extend as Tessier 10 or 11.
Okay, that covers the oral nasal group well. Let's move laterally to the oral ocular clefts. Tessier 4 through shuts, connecting mouth and orbit, but sparing the nose, running through the cheek.
Exactly. Tessier 4 is, well, it's complex, quite disruptive. Can be unilateral, bilateral, or even combined with others. Soft tissue starts lateral to Cupid's bow, sort of between the commissure and philtral crest, goes on to the cheek lateral to the ala, then curves up into the lower eyelid medial to the punctum.
Disrupting the eyelid structures.
Usually, yes. Lower canaliculus, inferior support structures often hit. Colobomas are common. But the medial canthal ligament and the main lacrimal apparatus often intact, surprisingly.
Skeletal pattern for Tessier 4.
The nose often gets pulled superiorly, especially if bilateral. Clefts starts between lateral incisor and canine, runs onto the anterior maxilla lateral to the piriform, but medial to the infraorbital foramen. It disrupts the medial and inferior orbital walls.
Right. And Tessier number 5.
5 is the rarest of this group. Soft tissue. Starts medial to the oral commissure, runs along the cheek lateral to the ala, and ends up in the lateral lower eyelid.
Skeletal course.
Starts lateral to the canine, passes lateral to the infraorbital foramen, and finishes in the lateral orbital rim and floor. You might see a thickened lateral orbital wall or an abnormal greater wing of the sphenoid.
Okay. What about Tessier number 6?
6 is interesting. It includes incomplete forms of Treacher-Collins syndrome. It's sort of a transition towards the lateral facial clefts, but the ear is typically normal.
Soft tissue signs.
You see a vertical furrow, often from the oral commissure up to the lateral lower eyelid. There's that characteristic downward pull of the lateral campus, anti-mongoloid slant, ectropion and lower lid colobomas too.
And skeletal features for 6.
Choanal atresia is common. The cleft itself connects to the inferior orbital fissure. You'll see a hypoplastic zygoma and often a narrowed anterior cranial fossa.
Okay, that leads us nicely into the lateral facial clefts proper, Tessier 7 through 9, and the related syndromes like Treacher-Collins and Goldenhar's. Let's start with 7.
Tessier 7. This is the big one, the most common craniofacial cleft overall, often seen with craniofacial microsomia.
Okay.
Soft tissue involvement is variable. It runs from the oral commissure laterally towards the ear, can be just a mild broadening, or a full fissure stopping at the anterior masseter. Ear deformity is common, from skin tags to full microtia.
And skeletal involvement.
It cuts through the pterygomaxillary junction. You get hypoplasia of the posterior maxilla and the mandibular ramus condyle coronoid process. The zygoma is typically hypoplastic, often displaced. Asymmetrical cranial base, maybe an open bite or cross bite.
Nerve involvement.
Yes, cranial nerves V and 7 paresis are pretty common with Tessier 7. It affects the orbit, mandible, ear, soft tissues, and facial nerve.
Right. What about Tessier 8?
8 is rare, almost always found combined with another rare cleft. It's largely an orbital cleft. Soft tissue. Think coloboma of the lateral commissure, maybe an absent lateral canthus.
Skeletal.
Involves the frontozygomatic suture. Zygoma might be hypoplastic or completely absent. Lateral orbital wall can be missing, so the orbit and temporal fossa are continuous, associated with Goldenhar's syndrome.
Okay. And Tessier 9.
9 is extremely rare, sometimes associated with encephalocele. The hallmarks are in the soft tissue. Abnormalities of the lateral third of the upper eyelid and brow. Microphthalmia is possible but uncommon. Facial nerve palsy affecting the forehead and upper lid can occur.
Skeletal features of 9.
Hypoplastic greater wing of the sphenoid. This pushes the lateral orbital rim posteriorly, and you get a reduced dimension of the anterior cranial fossa.
Now, you mentioned syndromes. Let's touch on Treacher-Collins specifically.
Right, Treacher-Collins. Think bilateral Tessier 6, 7, and 8 features. It's autosomal dominant, gene on chromosome 5. Key features are that lower lid coloboma and retraction, the anti-mongoloid slant. Hypoplastic lower lid lashes.
What else?
Redundant upper lid tissue laterally, looks like ptosis sometimes. Inferiorly displaced lateral canthus. Absent zygomatic arch. Hypoplastic malar bones, mandible, temporalis muscle. Ear malformations are classic. And abnormal hairline tongues. Absent lateral inferior orbital rim is also typical.
And critical point for newborns.
Airway. Absolutely critical that narrow pharynx and short mandible can cause real problems right after birth. Needs careful management.
Good point. And Goldenhar's syndrome, how does that fit in?
Goldenhar's is usually sporadic. Features include prominent frontal bossing, low hairline, low set ears, mandibular hypoplasia, often asymmetric, upper eyelid colobomas, epibulbar, dermoids, those yellowish growths on the eye, bilateral pericular tags or appendages, and vertebral abnormalities are common too, associated with Tessier 8, as we said.
Okay, comprehensive.
I
Now
think
let's move superiorly to the cranial clefts. These extend up from the orbit towards the midline through the frontal bone, Tessier 10.
10 is considered the cranial extension of Tessier 4. Soft tissue involves the middle third of the upper eyelid and brow. You see a coloboma there, an irregular, retracted central brow.
Skeletal.
Cleft is at the middle orbital rim, lateral to the supraorbital foramen. Encephalocele are common. Hypertelorism results from the orbits rotating inferolaterally, and distortion of the anterior cranial base.
Tessier 11.
11 often combines with Tessier 3, soft tissue, coloboma in the medial third of the upper eyelid and brow, disruption extending to the hairline. Skeletally, you get extensive ethmoid pneumatization, causing hypertelorism and potentially encephalocele, but the cranial base itself is usually normal.
Okay. Tessier 12.
12 extends from Tessier 2, soft tissue. Cleft is medial to a laterally displaced medial canthus. Colobomas up to the eyebrow root. A characteristic downward-pointing V shape in the paramedian frontal hairline.
Skeletal findings for 12.
Orbital hypertelorism and telecanthus from increased ethmoidal cells. Sinuses, frontal, and sphenoid can be very pneumatized. The cleft runs lateral to the cribriform plate, enlarged anterior and middle cranial fossas.
Tessier 13.
13 extends from Tessier 1. Soft tissue. Often a paramedian frontal encephalocele located between the nasal bone and the maxilla's frontal process. Another V-shaped frontal hair projection. Skeletally, hypertelorism again, with a widened cribriform plate and ethmoids. The encephalocele pushes the cribriform plate down, orbital dystopia.
And finally, the true midline cranial cleft, Tessier 14.
14 extends from Tessier 0. Often involves significant CNS abnormalities, herniation of brain tissue. Life expectancy can be severely limited if it's a true herniating cleft. It can manifest as either too much tissue or too little.
Examples.
Abundance, think hypertelorism, midline encephalocele along midline frontal hairline. Agenesis or deficiency. This is often linked to holoprosencephaly. So hypotelorism, microcephaly, severe CNS problems, even cyclopia. The facial deformity usually mirrors the severity of the forebrain malformation.
Skeletal features in 14.
Medial frontal bone defect, often where an encephalocele emerges. Midline structures like the cristogali perpendicular plate of the ethmoid can be bifid. Cribriform plate displaced downwards, and that harlequin deformity of the orbits due to the upslanting anterior cranial fossa.
Wow, very complex. Is there one more, number 30?
Yes, Tessier 30 is the midline mandibular cleft. Soft tissue, notch in the lower lip. The anterior tongue might be bifid, sometimes attached to the mandible by a fibrous band.
Skeletal.
Cleft runs between the central incisors down into the mandibular symphysis. The hyoid bone might be absent and the thyroid cartilage incompletely formed.
Okay. Briefly then, what are the core principles for reconstruction in these complex cases?
It absolutely has to be a multidisciplinary team approach. Initial focus is usually on soft tissue closure, excising scar within the clefts, meticulous layered closure.
And skeletal work.
Often delayed until later childhood, depending on the specifics. The goals are functional, correcting macrostomia is present, reconstructing eyelids to protect the globe, separating the oral, nasal, orbital spaces, and of course, aesthetic improvement.
Right. So distilling this down for board preparation, what are the absolute key takeaways?
Know that Tessier 7 is the most common. Remember, Treacher Collins involves Tessier 6 through 8, bilaterally typically. Goldenhar's is associated with Tessier 8 features. And most importantly, internalize that Tessier diagram. Know the locations relative to the midline. That's fundamental.
Excellent summary. Thinking back on the embryology we discussed right at the start, it really underscores how disruptions at different points in that complex developmental cascade can lead to such a diverse, almost bewildering spectrum of cleft presentations.
It really does. It highlights how intricate and sensitive that period of facial formation is.
A fascinating and vital topic. Thank you for this detailed and very clinically focused review.